Beautiful, we got it.
All right, well, let's get started then. Again, thanks a lot for everyone for joining me today. This is supposed to be a 2-hour talk. This is the longest probably you've listened to, but hopefully it won't be that boring, and I'll try to mix it up. And the purpose of this talk is to discuss different supraventricular arrhythmias. No disclosures. The objectives of this talk is to identify the different types of supraventricular rhythms, to also discuss the mechanisms of tachyarrhythmias, to identify the different types of supraventricular tachyarrhythmias, and to discuss the role of catheter ablation in managing supraventricular tachycardias. And last is to classify the degrees of the AV blocks. This is just to highlight that the vascular supply, the arterial supply of the heart muscle, and the venous return, all the vascular system is epicardial. And this is in contrast to the electrical system of the heart, which is mainly endocardial. In this drawing here, you can see this is the representation of the sinus node, which is actually the exception, and that is an epicardial structure. But when it comes to the AV node, to the right bundle and to the left bundle, these are all sub-endocardial structures. Why is that? Because I think the electrical system is more important than the plumbing system. At least that's what I tell my interventional cardiologist partners. But you can see the relationship between the blood supply, the arterial branches, and the electrical system. So those coronary arteries with the right coronary artery here, the left coronary artery with the left anterior descending artery, and the left circumflex artery, you can see they don't only provide the blood supply to the heart muscle itself, they also provide specific branches to supply the different parts of the electrical system. So in this case, the proximal part of the right coronary artery is giving a branch to the sinus node, another branch to the AV node, and you can see the branches here to the bundles. And the left anterior descending artery from the left coronary artery giving the main supply to the bundles, the right bundle and the left bundle. This is an important relationship to understand before we go and start learning how to read the ECGs and different kind of supraventricular arrhythmias, because if you happen to have an acute myocardial infarction and block in the proximal portion of the right coronary artery, you can imagine why you would have a sinus node arrest or sinus bradycardia. And if you block the supply to this artery, why would you have a complete heart block in the setting of inferior myocardial infarction associated with occlusion of the right coronary artery? And it also explains why you might have a left bundle or right bundle branch block when you have acute anterior myocardial infarction. If we intervene and open the artery, it is not surprising that the blood supply would resume and conduction would return, and you would not need or may not need to go ahead and put a permanent pacemaker in place. This is just something I want to highlight before going further with the electrical system. Another thing I would like to highlight, and this is basically the right side of the heart. We took the free wall of the right atrium here and the right ventricle and opened them up. So we can see the sinus node here, again, the only epicardial structure of the electrical conduction system. We can see the AV node, the Hus bundle, to the left, to the other side, you go to the left bundle, and here the right bundle. If we do the same and open the left side of the heart, this is the left atrium, this is the left ventricle, you can see the big branching tree of the left bundle. It's important to realize that the right bundle is very thin and very superficial subendocardial, to the point when we do EP study and put a catheter in, just the fact it touches that bundle, it can create a temporary or transient complete right bundle branch block. If you have a pulmonary hypertension patient, he or she may present with a right bundle branch block. If you put a Swan-Ganz catheter in, you may have a right bundle branch block. So be careful with all these things in somebody who already has a left bundle. When you put a catheter in, you may create a complete heart block. Right bundle branch block, it is not a big deal. It's a common thing. It is easy to do. It's easy to have. But if you have a left bundle branch block, that is really something you need to be concerned about, and you certainly need to go ahead and do more workup than just an ECG. Even those patients with left bundle branch block who we do an echocardiogram, MRI, cardiac stress testing, and we fail to find a reason for it, they still don't do as well when they are followed for the long term. So this is again to highlight, right bundle very thin, left bundle like a big branching tree. To simplify the electrical system of the heart, it's simply decided or divided into the sinus node, which is like the electrical generator and simple wiring system. The main cable is the AV node, and it's two wires. One goes to the right bundle, and one goes to the left bundle. So electrical generator, sinus node, and cable with two branches. If we look at it like this, I think it will be easy to read the 12-lead ECG and discern all kinds of supraventricular arrhythmia. 12-lead ECG, as we all know, it came because you have 6 limb leads and 6 chest leads, and that will give us the 12-lead ECG. To simplify it for you and to make it easy to look at the 12-lead ECG and quickly decide what kind of rhythm you have, I'm going to just ask for the purpose of this lecture to focus on only 3 leads. So lead 1, lead 2, and lead V1. If you focus on these 3 leads, and I think you will be able to read 90–95% accurately and very fast of all kinds of arrhythmia. Before reading the ECG, just like before relying on the recording of an arterial line, we need to zero that arterial line. The same thing for 12-lead ECG. We need to make sure that that 12-lead ECG recording machine is set according to the accepted standards. The 2 main standards are the paper speed, 25 millimeter per second, and the gain, 10 millimeter per millivolt. How do we know that? Every 12-lead ECG, and I hope you start looking at that, every 12-lead ECG will have that somewhere. The top, the bottom, the side, you will find it. In this case, see, limb leads have 10 millimeter per millivolt gain, chest leads 10 millimeter per millivolt gain. Speed, 25 millimeter per second. That square thing that you see at the beginning, and sometimes you see it at the end of the strip, that's simply a 10 millimeter per millivolt test. That's the machine test itself. Gives 1 millivolt, it gets 10 millimeter. When you look at this, if it's 20 millimeter, that means you have double the gain. And if you see an QRS that suggests LVH, that's probably not an LVH. And if you see that as 5 millimeter, that's half the gain. And you may miss an LVH if it's present. When would I personally go from 10 millimeter to 20 millimeter? When we have P wave that's hard to discern, hard to see, then I double the gain. It's like looking at the P wave or the underlying atrial activity with a magnifying glass. The point is, look first at the gain and the speed. And how important that is? It is really important. Because if you look at these strips I just got from our telemetry strips, quick look on the top, you see it fast. You have tachycardia here, heart rate about 100 beats a minute, here about 200 beats a minute, here it's about 50 beats a minute. So you say, okay, almost a Brady, normal range, really fast. But when you look at the speed, 25 millimeter per second is the speed for this strip. Well, that's not concerning. Heart rate about 95 to 100 beats a minute. This is the exact same strip. I made it 12.5 millimeter per second. The paper is very slow, allowing the QRS complexes to be inscribed closer to each other. And it can fool you as a heart rate of 200 beats per minute. And if you look here, the same strip, I doubled the speed, 50 millimeter per second. That fast paper speed make those QRSs farther apart and give us the impression of bradycardia. Why am I highlighting this? Because I've had consults for tachycardia and bradycardia where the speed was the issue. And you can see here the gain by looking here. This gain is not the normal 10 millimeter per millivolt gain. You increase the gain, you increase the amplitude of the QRS, and it gives you the impression of an LVH that doesn't really exist. So the ECG is the recording of the electrical activity of the myocardium. For simplicity, again, we'll try to simplify things without affecting the accuracy of ability to read the ECG with accuracy and speed. The heart divided into two muscle masses, atrial muscle and ventricular muscle mass. Activation of the atrial muscle mass will give us a P wave. Activation of the ventricular muscle mass will give us the QRS. As the impulse is going between the atria and the ventricles, it's going through the AV node with no muscle fibers. So you get isoelectric line. You have no electrical activity to record. And the two muscle masses are separated by the annuli, the AV valves, the tricuspid valve on the right and the mitral valve on the left. Those annuli are fibrous tissue and will not allow conduction between the atria and the ventricles. So normally the AV node is the only normal electrical connection between the atria and the ventricles. Again, to simplify it more, and for the purpose of deciding the rhythm, look at P, PR, QRS. Forget about the ST and T wave for now. Why? Because the ST and T waves are helpful to evaluate the blood supply. So plumbing is ST, T wave, electrical, P, PR, QRS. Normal intervals, quick way to figure it out. You have PR interval, usually one big box is the upper limit of normal. Each millimeter is 40 millisecond. When you say 25 millimeter per second, that's 25 millimeter per 1,000 millisecond. Each millimeter is 40 millisecond. 5 millimeter, which is the dimension of those boxes here, the big boxes, is 200 millisecond. The PR interval should be contained within that big box to be normal. The QRS duration should be 100 millisecond or less, which is half big box. So quick look, you'll find PR within a big box, QRS half or less big box. Then you're dealing with normal activation times. Here, just to highlight, this test, 1 millivolt test, gives you 10 millimeter. So most of us learn and probably continue to practice to look at the P wave first when we look at the 12-lead ECG. Again, I don't want to emphasize the importance of looking at the gain and the speed, but I would like you to start looking at the QRS first. And now we learned, if you look at the QRS, if it is 100 millisecond or less, that means it's narrow. Narrow QRS, we're talking about timing, the time it takes to activate the ventricles. To activate the ventricles fast, the impulse has to come down from the AV node area down both bundles very fast. Think of the bundles as highway. You go really fast down that highway. And to go down both bundles to activate ventricles at the same time and finish the QRS in short time, you have to come down from the AV node down both bundles. So narrow QRS, you have fast conduction through the AV node and the normal bundles, fast activation of both ventricles, and the QRS duration is certainly less than 120 millisecond. Normal is 100 or less. Again, less than 120, still considered narrow for all practical purposes. If you travel down the myocardium, not down the bundles, you're gonna go through dirt roads instead of going down highways, and you take longer time, and that's when the QRS start to widen. So anytime you have narrow QRS, you already established the impulse starts from this point down. So you have to be coming either from the AV node or above. The level above the AV node, that's what we call the supraventricular zone or region. So once again, narrow QRS going down the AV node and normal, fast conducting bundles, you have supraventricular rhythm. That's very easy and very fast. Look at the 12-lead ECG, narrow QRS. Now your attention is shifted only to the supraventricular rhythm. You forget about this area. So to summarize, narrow QRS, you have supraventricular rhythm, and you are excluding bundle branch block. Again, when we evaluate the rhythm, we look at where the rhythm is coming from, to think of the electrical generator, where it is, and how is it being conducted, how it's traveling. And we only have the AV node and the bundles to think of. So you can divide the whole conduction system into a generator and two main wiring components, AV node and the bundles. So narrow QRS, supraventricular rhythm, and no bundle branch block. So let's dissect that further. Supraventricular rhythm, it's really limited options, either sinus or atrial or junctional, no other. We're not going to have pulmonary rhythm or pericardial rhythm, one of these three. So let's see how we can quickly and accurately decide what kind of supraventricular rhythm we have. But before going any further, another simple rule. The bigger the muscle mass, the bigger the electrical activity we're recording or the deflection. And activation in the direction of the recording electrode will give us positive deflection. Activation away in the direction away from the recording electrode will give us negative deflection. If we know these two simple rules and we know the location of our recording electrodes and the activation, the direction of the activation wavefronts, we should be able to accurately read any rhythm problem the patient may have. So, supraventricular rhythm, sinus, atrial, or junctional. Sinus rhythm, again, I promise you all you need to look at is lead 1, 2, and V1. Sinus rhythm, the sinus node is located in the top of the right atrium. So the activation will be going from the right atrium to the left and from the top to the bottom. If we look at lead 1, which is recording between the right arm and the left arm, you can see activating the atria, if it's coming from the sinus, will be going in the direction of lead 1 and will be going in the general direction of lead 2. If it's positive in lead 1, that means you're coming from the right to the left in the same direction. If it's positive in lead 2, you're going in the direction of lead 2 from the top to the bottom. What is in the top of the right atrium? That's the sinus node. So if you have 12 lead ECG and you look at the QRS, it's narrow, we have supraventricular rhythm. Try to find the P wave in lead 1 and 2. Don't bother looking at other P waves for now. Positive in lead 1, it's coming from the right atrium. Positive in lead 2, it's coming from the top of the right atrium, that's sinus. So positive in lead 1 and lead 2, P wave, that's sinus P wave. Now the other options, if you have atrial rhythm, and atrial rhythm could be coming from anywhere in the atria, anywhere in the right atrium, anywhere in the left atrium. Sometimes it could be confusing when the spot of the atrial rhythm is close to the sinus node, making it difficult to distinguish, but we have other features we can rely on. Nonetheless, if you have atrial rhythm, whether it's left atrial or right atrial rhythm, we can look at it and evaluate it the same way. Look at lead 1 and lead 2, and in this case, let's evaluate the possibility of the rhythm coming from the left atrium. Now, activating the atria would be going from left to right. It's going to be in the opposite direction to lead 1. That will give us negative P wave in lead 1. And if it's coming towards the top, let's say from the bottom to the top, it's not going to be positive in lead 2, and we may record a negative recording or P wave in lead 2. So, as a rule, once again, let's look at this ECG quickly. Practice narrow QRS, supraventricular. Options are sinus, atrial, or junctional. To be sinus, it has to be positive in lead 1, which is positive in lead 2. It's not. So it's not sinus. The option left is atrial. Junctional is the third option when you have supraventricular rhythm, and that's easy to figure out. If you're coming from the AV node area or from the junctional area, you will be going up and down at the same time. So the P wave will be hidden behind the QRS or shortly after the QRS. We learned a lot of times that when you see a P wave negative before the QRS, that's junctional. I think that's still called low atrial. Anytime you see a P wave before the QRS, it is not junctional, it's atrial. I've been doing EP for 21 years, never seen junctional rhythm recorded and verified intracardiac and surface ECG where P wave precedes the QRS in a visible way in 12 lead ECG. So having a narrow QRS with no P wave, that tells us it is junctional. And this is an example. Again, narrow QRS, supraventricular, options sinus, atrial, or junctional. No P wave, it can be sinus, it can be atrial. You're left with junctional. Sometimes when you don't have a P wave before a narrow QRS, it's junctional. You may be able to see the P wave just after the QRS. So to summarize, when we have narrow QRS, it's supraventricular rhythm. Look at lead 1 and 2. Positive in lead 1 and 2, that's sinus. Any other P wave morphology, that's atrial. No P wave, that's junctional. Any questions? Just tell me you guys are awake. Somebody.
We're awake.
Oh, okay. At least
Listening, just making notes. Sorry.
No problem. Thank you very much. We have at least 2 awake. That's good enough. Let's keep going. Now, this is a good display. All these our patients actually strips without violating any HIPAA. So this is ECG. You can see lead 1 and lead 2. Again, never forget the speed and the gain. In this case, you can see the speed, 25 millimeter per second. The QRS, you will get used to it. It is narrow. This is a big box. This is less than half big box, narrow QRS. Options are sinus, atrial, or junctional. If we look for P wave, we can see P wave positive in lead 1, positive in lead 2. That's sinus. Keep going, keep going, keep going. The P wave flips. When the change in P wave occurs, now we're moving from sinus to atrial. And you can see the P wave is negative in both. So it's negative in lead 1. So it's coming from the left atrium to be going towards the right. It's negative in 2. It's coming from the bottom up. So just looking at these 2 strips, not only we know it's not sinus and it's atrial, we know exactly where it's coming from. In a sense, in the bottom, coming from the bottom of the left atrium. For you, it's not a big deal. For us in EP, it is. Because if we are going after a spot that's firing very fast and causing problem, it helps to know before we start if we're going to go to the left atrium or stay in the right atrium or go somewhere else. So it helps to know, and it's also a joy to know where things are happening and how it's happening. If you look at this strip here, narrow QRS, supraventricular, sinus, atrial, or junctional. No P wave, exclude sinus or atrial, you're left with junctional. So this is just a nice display. And look how this rate did not change at all. This is just the sinus node decides to slow down, and the atrial rhythm, which you can think of as escape atrial rhythm, took over. The patient will not feel it. You check the pulse, doesn't make any difference. And the junction here is taking over simply because there is no sinus node. So these are nice rhythm. These are escape rhythm. What do we do about them? Nothing. Just enjoy the fact you can distinguish them, and the patient has them as a backup rhythm. And there's no specific therapy other than making sure there's no reversible cause for the sinus node to be slow that you can reverse. And if you have sinus node dysfunction, that's been symptomatic because the heart rate slows down too much, that's when you may need to think of the possibility of needing a pacemaker. This is another practice ECG. I usually have you guys do it, but I'm going to enjoy doing it myself. So here, this is the best place to be for 12-lead ECG. And you can see the speed and the gain in one corner. You can see the test, 1 millivolt. QRS, look at it, narrow. And this to highlight another thing. RSR prime or rabbit ears, we always look at them and say there may be a right bundle branch block. The point I want to emphasize on, it doesn't matter if this patient has RSR prime. If the QRS is narrow, 100 millisecond or less, it is not bundle branch block, regardless what the shape of that QRS is. Narrow QRS excludes bundle branch block and tells us it's supraventricular rhythm. Let's look for the P wave. Lead 1, I don't see a P wave, and you think, oh, is that junctional? But you look at lead 2, you see nice P wave. That's inverted, so it's going away from lead 2, from the bottom up. This is atrial rhythm. So this is basically a simple way of looking at a 12-lead ECG and decide it's supraventricular rhythm, and a quick look for a P wave or lack of P wave in lead 1 and lead 2, we can quickly decide if it is sinus, atrial, or supraventricular rhythm. Now let's talk about supraventricular tachyarrhythmia or tachycardia. We look the same way, 12-lead ECG, approach it the same way. And I keep telling anytime I talk about reading ECGs, I remind people that to read ECG accurately, we need to go through the same steps every single time. If anybody able to read ECG faster than somebody else, they are not skipping steps. They are just getting used to going through the steps faster, just like typing. I can tell you, I can type maybe 5 words a minute, thank God to the voice recognition now, and somebody can type 100 words a minute. The person who types 100 words does not skip a letter when they are typing. They are just going faster through the same steps. So reading ECGs, believe it or not, I still look at the gain, speed, and go through the same steps I'm telling you now. So we look at the 12-lead ECG the same way. Let's skip to the QRS. It's narrow, so it's supraventricular rhythm. It's fast, assuming the paper speed here, of course, it's 25 millimeter per second, 10 millimeter per millivolt gain. It is tachycardia, so this is supraventricular tachycardia. The fact it's narrow and tachy makes it supraventricular tachycardia. And let's go, before we talk about what options we have, let's talk about the mechanisms of tachyarrhythmia. No matter how you look at it, you have 3 main mechanisms for the heart to go fast. Either what we call enhanced automaticity, think about it as a sinus rhythm, an automatic focus that goes faster, that's enhanced. Triggered activity, think of it as a focus in the atria, for example, that's not supposed to be there, but it's triggered and cause the heart to go fast. That's triggered activity. Re-entry is basically a reentrant circuit, a wave front of activation that goes through a specific path. And every time it completes its circuit, it gives an impulse that propagates and go throughout the heart, the chamber where it starts and the rest of the heart. So enhanced automaticity and triggered activity, you think of both mechanisms as focal, one spot, firing fast. So really for reading the ECG, it doesn't matter what kind of mechanism it is, but it matters to know if it's a focus or a reentry, and we'll figure out why it is. And when I was thinking about the reentry, I want to show you something I see every day. We all log on the computer, and this wheel that never ends is the worst reentry I see every day. And I wish I can ablate it, but this is a reentry. This is the reentry all of you will be seeing tomorrow, hopefully, and you'll never look at your computer the same way again. This is a reentry. And this is a circuit of activation that keeps going all the time. And there's a big difference in how we approach by therapy and by ablation when it is a reentry circuit with a path or a focus. If you have a focus, in order to be successful in ablating that focus, you really have to go to that spot with the catheter and be within 5 millimeter accurate in finding that location. When you have a reentry circuit, especially when it's a macro or big reentry circuit, theoretically, you can go anywhere in that circuit once you define where that circuit is and put a roadblock and stop that circuit. So there's a big difference. Once again. So we have supraventricular tachycardia. We decided we have narrow QRS, that's fast. Supraventricular tachycardia. Options are simple. Sinus node area, atrial area, junctional area. When you have sinus tachycardia, that's an example of enhanced automaticity or focal kind of tachycardia. It's easy to recognize. Your sinus tachycardia usually is a secondary phenomenon to something else going on, fever, pain, anxiety, hypotension. And it's usually gradual in change in heart rate, up and down. You will see like a sand dune or a hump. That's typical of sinus tachycardia. You don't need to specifically treat that. There is an entity called inappropriate sinus tachycardia. It is not a common one, and its treatment could be challenging. But for sinus tachycardia, you really need to treat the underlying cause. P wave morphology would look the same as that P wave during sinus at normal rate, positive in lead 1 and lead 2. So the next option when you have narrow supraventricular tachycardia is atrial tachycardia. Once again, P wave morphology will be different from that of sinus. Anything that's not sinus tend to be sudden onset and termination, which is another example or feature that will help us distinguish sinus from atrial tachycardia. And as I said, the mechanism could be focal or reentrant. And then we'll go through the options. You can have one focus, you can have multiple foci, you can have one circuit or multiple circuits. Once we have those in mind, we'll be able to recognize all kinds of atrial tachyarrhythmia. So we just discussed sinus tachycardia. Now let's talk about atrial tachyarrhythmia. One focus, that's focal atrial tachycardia. And again, that focus could be anywhere in the right atrium or in the left atrium. And the key is to look at the P wave morphology. And it is not positive in lead 1 and lead 2. Could be negative in both or negative in one of them. In this example, the P wave is going to be negative in lead 2 because it's coming from the bottom of the right atrium and it's going to be activating upwards. And actually, this is the actual ECG of a pregnant lady we took care of, where she came in with tachycardia that we know it's narrow QRS tachycardia. The rate is about 120, 130 beats a minute. We look for the P wave and it is negative in lead 2, so it's not sinus. And that was focal atrial tachycardia. You can see the speed 25 millimeter per second, and we can see the gain is 10 millimeter per millivolt. When, as we discussed, if the spot in the right atrium close to where the sinus node is, you may see a P wave. This is sinus P wave. You can see the morphology of it. And this is tachycardia. See, the heart rate sped up all of a sudden for a few seconds, then went back to sinus rhythm. The P wave here looks very close to the P wave during sinus rhythm. What that means, the spot that's firing fast is actually close to the position of the sinus node. How do we distinguish between this being sinus tach versus atrial tach? Look at the sudden onset and termination. A switch turned on and off. That's not typical of sinus tachycardia. We see usually gradual increase in heart rate in case it is sinus tachycardia. And this is again from telemetry. Hopefully you all look at the trend when we review our patients, when we round on them. So this, you can see, this is sinus rhythm here, and you can see burst of increased heart rate. You can see it here, you can see it here, you can see it here. And if you look at the average heart rate, this is 65, 105, 145, and it gives us the average over the last, let's say, 8-10 hours. You can see sudden increase and go back to baseline, sudden up, sudden down, up and down. This patient suffered terrible paroxysmal focal atrial tachycardia that we took care of. But I'm just showing you this to show you what sudden on and off is. This cannot be sinus tachycardia. This is anything but sinus tachycardia. So this is just to show you an example, the difference between sudden and the gradual increase in heart rate. When we talk about one focus in the atria causing the heart to go fast, studies have shown that there are limited area where that spot could be. Most of the spot that could be firing and cause focal atrial tachycardia, almost 85%, is usually in the right atrium and usually in the crista terminalis, which is the crest in the right atrium on the lateral wall that separate the smooth muscle in the back from the trabeculated in the front. And the sinus node actually is at the top of that ridge. We call the crista terminalis. Other areas could be the opening of the pulmonary veins in the left atrium or the base of the appendage in the left atrium. And that's not usually the majority. The majority is in the right atrium. So when we have somebody with focal atrial tachycardia and relying on this, we can just say chances are it's coming from the right atrium. So when we go in to ablate that spot, we go through the vein and the right femoral vein and go up to the right atrium, try to find that spot. But of course, as we will see in future slides, We have a lot of catheters and electrodes recording from the right atrium and the left atrium, so we know where that spot is, just in case it's not in the right atrium. But we just mentioned, if you have a 12-lead ECG, and if the P wave is negative in lead 1, you can say with a lot of confidence it's coming from the left atrium, because the activation is going from the left to the right in opposite direction to lead 1. This is a patient we did, I think about 2 weeks ago. I thought I'll bring you fresh animation. And the technology we have is so amazing now that it's really such a joy to figure out what's going on. So the technology we have allows us to go inside the chamber, touch, make contact with the wall of that chamber. In this case, the right atrium here, the SVC there, the IVC here, then cross to the left side and go inside the veins. So we record all the veins. And that software connect all these spots to create a 3D geometry of those chambers. And this is the aorta here. And then it gives us the activation timing of that spot that's firing. The earliest spot gives us red. The latest spot gives us blue and purple. So by going inside the heart, as the heart is going fast, we record the timing of the different spots. And that software tells us where is the earliest. And then we go to that earliest spot. And this is the ablation. One ablation lesion terminated that focus that was causing this young lady to have focal right atrial tachycardia. So if we have one focus causing the tachycardia, we call it focal tachycardia. How about if we have multiple foci? We call it multifocal atrial tachycardia. The key thing, though, that the different spots in the right and left atria that are firing fast, each comes from different spots. So as we discussed, the vector of activation will be going in different direction depending where the spot is. And as a result, we'll be recording different morphology P wave in different leads. If you look at lead 1 and 2, and let's look at these strips here of that patient with multifocal atrial tachycardia. By definition, you should have at least 3 different P wave morphology with different PR intervals, because they are usually at different distance from the AV node that participate in deciding how long that PR interval is. Look at this P wave. You can agree certainly that it looks different than this P wave, which is down, and then this P wave, which is much higher. And you can probably figure out that this P wave is different. So you have easy 3, 4, 5 different P wave morphologies. When you first look at it, you might think, wow, this is atrial fibrillation. Well, we'll talk about that. But we agree that this is narrow QRS and it's fast. So it's supraventricular tachycardia. Let's run the algorithm. Is it sinus? No, because the P wave is different morphologies. Sinus should be the same morphology. Is it focal? Is it one focus? Well, it should be different from the sinus P wave, and it's the same every time. It's not. You have different discrete P waves. Again, when you look quickly at it, especially if you're looking at this rhythm strip, and that highlights the importance of looking at multi-strips, not only one lead. Don't just listen to the report that you get in the morning about a patient and say atrial fibrillation. It's hard to see P waves here, but no way we disagree that we don't see discrete P waves before each individual QRS. So this is a great example of multifocal atrial tachycardia. What do we do about that? Unfortunately, this is another rhythm that is secondary to underlying problem, usually lung disease, severe lung disease. And this is different treatment than atrial fibrillation. We don't have specific ablation. We don't need to anticoagulate. And that's why important to know and consider the possibility of multifocal atrial tachycardia anytime you think somebody has atrial fibrillation. Something called wandering pacemaker is the same as multifocal atrial tachycardia in principle, and that is having multiple spots firing. The difference between wandering pacemaker and multifocal atrial tachycardia is just simply the speed. You have different P wave morphologies and different PR intervals, but the heart rate is not greater than 100. That's the main difference. And this is an example of wandering atrial pacemaker. Again, NeuroQRS, supraventricular rhythm. Let's assume this is lead 2 and lead 1. P wave positive, oh, sinus. Wow, this is not sinus. This is down in lead 2. It's atrial. Down in lead 2, atrial. Up in lead 2, but different than this one. Wow, this is up and different than this one. You can see how many different morphologies. Each P wave is almost different from the other one. So each one comes from a focus that's firing and causing the depolarization of the atria. This is a good example of wandering atrial pacemaker. One key point on 12-lead ECG to distinguish between a focal versus reentrant. As I discussed, the reentry is a circuit that's going on all the time. Like that wheel you see when you open that computer. There is no point in time where you don't have an electrical activation of some part of the muscle. In focal atrial activity or focal tachycardia, you have that focus activating the chamber in a pulsed way, just like think of it as a flashing light. So in between the activities, you have nothing going on. So you will see isoelectric line in between the atrial activity. So whenever you see isoelectric line before activity, you can tell right away, this is focal arrhythmia, not reentrant. And why it's important, I just mentioned. The medications you pick to treat that could be different. The way you approach it for ablation is certainly different. So we discussed sinus tachycardia and atrial tachycardia as a result of being focal, whether it's one focus or multiple foci. Now let's talk about atrial tachycardia. That's a result of reentry. If we have one circuit, we call it flutter. If we have multiple circuits, we call it fibrillation. So that circuit could be in the left atrium or the right atrium. It doesn't matter. And it can be counterclockwise or clockwise. The point is, one circuit, flutter. And you've all heard of typical and atypical flutter. Typical flutter is basically a circuit, macro circuit, in the right atrium, using a specific area, we call it the isthmus, between the tricuspid annulus and the opening of the IVC, or the inferior vena cava. And it can go counterclockwise or clockwise. Atypical flutter, any circuit, anywhere in the atria that's not using the cavo-tricuspid isthmus. So it could be related to an incision that created a scar that allows the circuit to go around it. Remember, a re-entry circuit would require specific requirements, would require some boundaries, a scar, areas where the electricity cannot go, so it has to turn around that area and cause the re-entry. If the patient had prior ablation or maze procedure, when we do ablation, we create scar, and that scar, unfortunately, could be the basis for future arrhythmia, or scar that developed just as a result of remodeling and aging. So let's elaborate more about the typical flutter, because this is very common and we see it a lot, and it helps to understand its mechanism. So this is the heart with the electrical system, and this is the area we call the isthmus. The boundary is posteriorly the IVC opening, anteriorly the annulus of the tricuspid valve, and this area in between we call the isthmus. And typical flutter, a re-entry circuit going around through that isthmus in a counterclockwise, but also it can go in a clockwise fashion. Regardless whether it's a counterclockwise or clockwise, we call it CTI or cavo-tricuspid isthmus dependent flutter, and the treatment would be the same. Now, we are all familiar with this. Let's go again, practice fast, NeuroQRS, supraventricular rhythm. Let's look for P waves. Wow, lots of them, so it's not sinus. It has to be atrial. So options are focal or reentrant. Do we see any isoelectric line? No, no isoelectric line. This is not focal. Chances are reentrant. Is it exactly the same every time? Yeah, well, then it's one re-entry because it gives us the same morphology. So this is a re-entrant, one circuit in the atria. This is flutter. And the sawtooth appearance gives us what we call typical counterclockwise right atrial flutter. If you notice, the QRSs are evenly separated. And if you are checking this guy's pulse, you will notice it's regular mostly, and you can't tell if they are in sinus or not. So having normal or regular rhythm by checking the pulse or when you're listening to the heart does not mean the patient is in sinus. So please, let's not say sinus rhythm just by listening to the heart. And this is a good example how flutter could be regular. Every fourth beat conducts. This is an example of the same flutter, but irregular QRSs. Why? Because every fourth beat conducts here, the third beat conducts here, the fifth beat conducts here, the fourth. So variable conduction down the AV node gives us variable rate, and this is irregular. So atrial flutter could be regular or irregular. How do we figure that out when we do EP study? Well, this is the X-ray of a patient we did. We put the catheter in, loop it around in the right atrium, along the tricuspid annulus, and the tip here going towards the coronary sinus. And this is how it is located. Each two dots here is a pair of recording electrodes. So we have a lot of eyes inside the heart. The more spies you have inside the heart, the more you can tell where the activity starts and how it is spread. And this is the basis for it. You have recording electrodes inside the heart, and you have an activating wave front moving in this direction. You can imagine this pair of electrode will be recorded before this pair, before this pair. So when you see that kind of recording, you know it's going in that direction, and that will make it counterclockwise. And this is an actual recording. This is the sawtooth. This is what we see from inside the atrium. 20 poles we record from. And the timing of each recording electrode decides what direction it's going. You can see here, we record this pair, before this pair, before this pair, before this pair. And if you draw an arrow, you can tell this is counterclockwise flutter. That's how we know the direction of the flutter when you get the report about an EP study and an ablation we do. And to highlight the difference between a circuit or re-entry tachycardia versus focal tachycardia, this is recording inside the heart in the atrium, the activity of each circuit. Look, we start here, one beat, and ends up here. There's always activity going on, always activity the next beat. There is no area, no time where you have no electrical activity going on. That's typical of re-entry circuit. In focal atrial tachycardia, see, we finish activating the atria and nothing going on in between. So the time of activity that's going on is in the shaded area. In between, there is nothing going on. Just remember, there are always exceptions to the rules I'm telling you today, but if you remember these simple rules, you'll be accurate more than 95% of the time. So this is to highlight focal versus re-entrant. So how do we ablate atrial flutter? Remember, it's a circuit. It goes like this. So find a place where it's the shortest distance where the circuit has to go and create a scar. And this is usually the shortest distance. We touch inside the heart, starting from the annulus on the tricuspid valve, one dot at a time. We keep the catheter in contact with that spot for about 20-25 seconds, depends, and create a scar, move to the next spot, to the next spot. So we create a line, one dot at a time. That's how we do ablation and create what we call a line of block. So when the circuit decides to come around, it has to be stopping here. And that's how we stop the flutter for good. Success rate with this ablation acutely, close to 100%. I don't remember the last time any of us could not stop it acutely, but conduction sometimes return when one of those lesions does not create a scar, heals and the tissue in that area starts conducting again, which is less than 5% chance. That's when we come back and fill the gap and repeat the ablation. This is a pig's heart opened up. This is the tricuspid valve. This is the IVC opening here. And this is how we do the ablation. This is the tip of the ablation catheter touching that isthmus, remember, between the tricuspid valve and the opening of the IVC. This isthmus is the area where the circuit has to go. So we touch, deliver the radio frequency energy, create a scar, and move the ablation back one spot at a time and create this pale area. So when people think of ablation, think we destroy tissue in a way that is significant to the function of the heart. That's not true. The damaged area is very limited, and this does not affect the function of the heart, atrial or ventricle. And that's how we create the line of block. This is a patient. I was doing the ablation here. This is the flutter circuit going on. You can see the sawtooth appearance. As I complete the line, simply the circuit stops and sinus rhythm ensues. And again, look at the activity always going on. This is reentry, typical reentry circuit. Look at the sinus, one focus firing, one beat at a time, and nothing in between. Focal, reentrant. When you have a flutter, which is one circuit, and that typical isthmus, we call it typical. Anything else, we call it atypical. This is an example of a scar in the right atrium because of prior surgery on that patient and the circuit around it. And to stop that circuit, first we need to map where it is, and then we can create a line of block anywhere, either between the bottom end or lower edge of that scar to the IVC, or between that scar and the annulus of the tricuspid valve, and that will stop that circuit. Once again, focal atrial tachycardia, you go from one spot and you spread in all directions. Reentrant, you always have continuous activation following a specific path. Adenosine usually terminates tachy if you give high dose in case of focal. If you give adenosine to reentrant tachycardia, you simply block the AV node. You don't terminate tachycardia. And you all probably can relate to patients who are coming in with tachycardia and you give adenosine, you take away the QRSs because you block the AV node, and that allows you to see the underlying rhythm, whether it's atrial flutter or fibrillation. Flutter, we just learned, it's a perfect example of macro reentrant tachycardia, and fibrillation is a good example of multiple reentrant circuits. Neither one stops by giving adenosine. So we discussed one focus that gives us focal atrial tachycardia, multifoci, multifocal atrial tachycardia, one circuit, flutter, could be typical or atypical, and multiple circuits. Again, this is a simplified way of looking at atrial fibrillation because it's mechanistic description of how it happens. It's a little bit more complicated, but to simplify it, think of atrial fibrillation as multiple circuits going on at the same time in both atria, and that will give us the appearance of the typical atrial fibrillation rhythm strip. Again, narrow QRS, supraventricular rhythm. Look at the atrial activity, always ongoing. We know right away it can be focal, it can be sinus, it has to be reentrant because there is no isoelectric line. Is it exactly the same or changing in morphology? It's changing in morphology. Those little humps are different and bumps. So it's not one reentry, it's multiple reentry that gives us atrial fibrillation. Once again, the importance of looking at multiple leads. Here you don't see it as well as you see it here. And when atrial fibrillation terminates, you go back to sinus rhythm, typical focal activity with no activity in between. I want to highlight one type of atrial fibrillation that's called focally triggered atrial fibrillation. So let's look at the rhythm strip here. You have sinus, P wave. Let's assume this is sinus. Just trust me for this. Upright in lead 2, V1. In this case, this is sinus rhythm. You have PAC here, sinus, sinus, another premature beat, sinus, sinus, another premature beat. Then you have sinus and premature beat Sinus, premature beat happens here and gets us into atrial fibrillation. You can see the fibrillation waves here, and then what happens here? It changes to flutter. So you go from sinus, premature beat, triggers atrial fibrillation, which is multiple circuits, that organizes into one circuit, which is flutter. And we probably seen a lot of patients where we see atrial fibrillation and flutter occurring at the same time, meaning same hospitalization or at different times. So atrial fibrillation and flutter tend to occur in the same patients. Now, this is what we call focally triggered atrial fibrillation, because one focus gets the patient into atrial fibrillation. And we will see how important that is. This is another example. Lead 1 and 2, near QRS, P wave positive in lead 1 and 2, that's sinus. Sinus, look at the P wave flips. That's not sinus, that's atrial. Sinus, sinus, sinus. Keep going and you will find this P wave, and this P wave. They are all flipped and they look the same. So they are coming from the same place. But look at the timing of those P wave. This is early, but not really early. Earlier. And look at how early this, towards the end of the T wave. It happened at the critical time for the atria, and it triggered it to degenerate into atrial fibrillation. This is another great example of focally triggered atrial fibrillation. And it's important because theoretically, if you go after this spot and ablate that spot, you cure the atrial fibrillation. But let me talk further about the mechanism behind focally triggered atrial fibrillation. We are all familiar with R on T, which is PVC happens on T wave at the time the ventricles are not fully recovered and are vulnerable to degeneration into ventricular fibrillation. And that happens in cases of long QT interval and R on T and what we call torsade. And that happens to induce short run, and this is long run that actually resulted in shocking that patient. So if we understand R on T triggering ventricular fibrillation, a PAC in the atria act the same way. Not on the T wave for the QRS, on the T wave for the P wave. We don't see the T wave for the P wave. It's small or repolarization of the atria and maybe hidden behind the QRS. But the PAC can come early enough that the atria are vulnerable and not settled and did not complete repolarization to be ready for the next activation. And that can trigger atrial fibrillation. So this is just to highlight the mechanism of focal atrial fibrillation. Atrial fibrillation, again, in this representation, is a problem mainly of a left atrium. Atrial fibrillation happens in both right atrium and left atrium. But from a therapeutic standpoint and mechanistic standpoint, most of the triggers are in the left atrium, and the treatment mainly involve ablation in the left atrium. How did that come about? Well, in '98, Hessegier, in this group of patients, noticed that atrial fibrillation was triggered in 94% of the times by a PAC originating from one of the 4 pulmonary veins, with mostly superior pulmonary veins being the site of trigger. And other areas much less frequent. So the vast majority of triggers of atrial fibrillation in focal atrial fibrillation comes from the pulmonary veins. And this will explain how do we approach ablating atrial fibrillation. So if we look at the back or posterior side of the heart, focusing on the left atrium with the pulmonary veins, and if we look and dissect and look at the muscle fibers of the left atrium, actually the muscle fibers of the left atrium, they are like bundles of muscle fibers that cross at random, somewhat random way, and they go around the opening of the pulmonary veins. Think of the pulmonary veins as vessels or tubes that don't have atrial muscle fibers, but the welding points, if you will, or the connection between the vessel and the atrium has that fingers of muscle fibers or band that connect them. That area of connection the opening of the pulmonary veins is usually the source of the vast majority of the triggering PACs. And that's how we started the whole concept of ablating atrial fibrillation. So at the beginning, we used to go, remember that concept came about in 1998, 99. So we thought, okay, let's go after those PACs and ablate them so we don't have atrial fibrillation anymore. So we would go inside the left atrium, wait for those PACs, and perform different maneuvers, giving the patients isopril, pace very fast, trying to trigger those PACs to happen so we find where it's coming from. Sometimes we would wait hours before we have a PAC. And then once we have one, we say, whoa, it's coming from this vein. Let's go inside that vein and find again. And we wait again until that PAC comes up. Then we try to localize that spot and ablate it. So that has many limitations. Number one, it's too long to wait for one PAC and too hard to ablate when they are infrequent. Then we thought, okay, instead of going inside to find that spot with the risk of ablation and scarring and narrowing that vein and occluding it actually, let's decide which vein it's coming from and circle that vein with a scar. So whatever happens here stays here. Well, we did that. And then we found out when we silence one vein, other vein can become the trigger. And then we have to go back in and circle other veins. Then we thought, okay, once we go in, we don't care which vein is coming from. We're going to circle all veins. And when we try to circle all veins one at a time, we ran a risk of burning and scarring down tissue at the opening of the veins and occluding those veins or causing stenosis in the lumen of the vein that could be as small as 10 millimeter and can cause pulmonary hypertension and a lot of problems and shortness of breath. And then we moved from each vein being circled to circling both veins at the same time, staying away from the openings and having a minimum to no chance of causing stenosis of the pulmonary veins. And actually, in our experience doing thousands of cases since 2004, we have not had single vein occlusion. And that's the current approach. We go circle all veins, regardless of the type of the atrial fibrillation, and we can draw other lines if we need to. So this is an example that's a rare example of focal atrial fibrillation when you have one spot that's firing very fast. This is basically all you need to think about is this is very fast activity recording from inside the heart. And I put the ablation catheter in that spot and I started the ablation and boom, immediately after start the ablation, it terminates. You don't get that lucky and you don't get this nice slide all the time, but it's worth sharing to highlight the point. If you get the focus that's firing so fast, causing the atrial fibrillation, you actually terminate atrial fibrillation and restore sinus rhythm. But that's not the current approach. This is the current approach we're talking about. As I mentioned in the previous animation, we go inside the heart. This is the left atrium. We touch the walls of the atrium. We go inside the veins, touch the walls of the veins, and the software connect those spots and create a 3D geometry of that chamber with the veins, with the appendage. Not only this, the areas that has good signal, it gives us a color purple. The areas with no electrical signals, it gives us red. Areas with in-between signals give us the other spectrum, yellow, green, blue. So you can imagine inside the vein, you have some muscle wrapping around the opening of the vein, give us some electrical signal, and these are usually the areas of the PACs that triggers atrial fibrillation. And as you go inside the vessel, you don't have any muscle activity there to record, so it gives us red. So this is the voltage map before ablation. And these are the lesions I put in one dot at a time, go around the veins, and complete the circles. So you basically prevent any signal that's coming from the sinus when it comes to left atrium from going inside those veins. And you prevent any signal that comes from inside the veins from getting out to trigger atrial fibrillation. So once I complete that fence, I go in and record the voltage here. Guess what I get? Nothing. So now I turn this purple to red. Once again, this is not expected and has not been shown to affect the activity or the function of that atrium. But this is a good example. This is a recent patient. So you probably heard of patients requiring more than one ablation. Why is that? Well, this is a good example. Of one patient, I went in, I did the ablation, I created that scar, isolated all those veins, created no signal here, and the patient comes back, we test and find out that the areas we ablated are still perfect. But that patient had so many circuits going on in this area, and we had to do a lot of lesions. See how many dots? And that will kill all these circuits and change that to all silent tissue. Again, you say, wow, you killed that much. What's the function of the heart's going to be like? Well, most of the function of the contraction of the atrium relies on the contraction or the active contraction of the appendage. As long as we don't isolate the left atrial appendage, no major effect or significant effect on the hemodynamics or the contractility of the heart in any significant way. And you probably heard of conversion procedure, which the cardiac surgeon does. Dr. Lundquist does that for us, where we go behind the left atrium and create scar and ablate all this tissue using a scope that comes basically through the subxiphoid area into the pericardial space and do the ablation for us. And you say, why would you need the surgeon to do that? Because this is the area where the esophagus usually runs, and you don't want to burn next to the esophagus sometimes if it's too close, because it can cause a fistula that could be fatal most of the time. These cases, we rely on the surgeons taking care of those circuits. This is another recent patient we did, and this to show you the technology we have and how amazing it is. This is the catheter moving during the heart beating. We see the tip of the catheter. These are the dots. I put one at a time, and this is completing the fence. But what I want you to look at is, look at these numbers. That little tip of the catheter, that's like 3.5 millimeter tip, has so much technology embedded within that it tells us what's the force, that tip of the catheter touching the wall of the atrium in grams. So we don't push too hard, we don't cause perforation, and that has minimized our complication tremendously. It gives us how stable that catheter is. It's not shaky. It tells us the impedance, so we know if there is any clot or anything happening, so we stop right away. It tells us how long we've been burning, in this case, 7, 8 seconds. All that information gives us feedback, how stable, how effective our ablation is. The same patient, we finish the circles on the right, we're going and finishing this circle, on the left, we're finishing it on the right. This is looking from the back of the heart. And as you would expect, this purple will be void from any electrical activity, so it will turn red if we go inside and map it. But once again, gives us the force, the stability, how long we've been doing it in seconds, and the impedance and the time. And this is the same patient. You can turn things around in 3D and verify that you created the circle, it's complete, and you created a scar around those veins. And this catheter here in orange, actually a catheter inside the esophagus with a temperature probe at that spot. So anytime we heat close to the esophagus, the temperature probe sensor there tells us, because the temperature goes up, so we stop doing what we're doing. Most patients who have atrial fibrillation also have atrial flutter. So if you can see this collection of red dots there represent the block I created on the right atrium across that isthmus. And you say, wow, you created a lot of dots. Yeah, sometimes you end up repeating the lesions because every lesion to be effective has to be transmural and has to go through the full thickness of the atrial myocardium. And that part of the muscle in that isthmus sometimes can be really thick, and you require repeated ablations and high power to penetrate deep enough. Okay, we're done with anything related to the atria. One focus, multifocal atrial tach, one circuit flutter multi-circuits fibrillation. Now let's go to tachycardia coming from the junction. If we have one focus, that's junctional tachycardia, just like junctional rhythm. The only difference is it's fast, faster than 100 beats a minute. So if it's coming from the junction, you go up to the atria and down to the ventricles at the same time. As a result, you will not see a P wave. And also I was able to catch this rhythm strip here. Let's look at it. Narrow QRS, supraventricular rhythm. The rate is about 90 beats a minute. P wave up in 2 and 1. That's sinus, normal PR interval. So this is sinus rhythm or sinus tachycardia, mild sinus tachycardia. And then you see the P wave disappearing into the QRS, then going away, then flipping behind the QRS. Why? Because the spot in the junction here sped up faster than the sinus, took over, and started activating the atria in a retrograde fashion, giving us negative P wave because going bottom up. This is an example of sinus going into junctional tachy. So this is junctional tachycardia. How do you know junctional tachycardia? Narrow QRS with no P wave before it at fast rate, regular fast rate. And the digoxin toxicity is one of the things that can give us junctional tachycardia. We're getting close for those who are about to get bored or fall asleep. Now we talked about the junction being one focus causing junctional tachycardia. How about if we have a re-entry circuit in the junctional area? That's what you call AV nodal reentrant tachycardia, because the re-entry circuit involves the AV node and it is in close proximity to it. That's what we call AV nodal reentrant tachycardia. How can we distinguish that from junctional tachycardia? It's really hard. Even for electrophysiologists, relying on strips, 12-lead ECG is really hard, and sometimes it's really hard even with recording from inside, the intracardiac recording basically. But you need to understand the idea. Re-entry in the AV junction area, we call it AV nodal reentrant tachycardia. So every time this goes around, it goes up to activate the atria and goes down to activate the ventricles. Also, the P wave is usually buried within the QRS or after the QRS. How do we stop that tachycardia? We burn just posterior to the AV node. We just did one this afternoon, 19-year-old with this kind of tachycardia. You do everything you can to stay away from the AV node. If you burn the AV node, yes, you will stop the tachycardia, but unfortunately you will end up with a pacemaker. So you do everything you can to burn away from the AV node. That part of the circuit we call the slow pathway, that's necessary for the tachycardia, but not necessary for anything else. One spot, if we are in the right spot, is enough to stop that circuit and keep the normal conduction intact. And again, to show you the technology that allows us to see all that. We go inside the heart. We record every area where his bundle is recorded or where the AV node is, and create what we call cloud. So we know the location of the AV node and his bundle to stay away from it. And this is the his catheter recording that area. We have that catheter, this is an LAO projection, around the tricuspid annulus and going inside the coronary sinus. When we put a catheter inside the coronary sinus, we record from the left atrium, and this records from the right atrium. You see, with one catheter, we are hugging both atria and recording from both. So if something starts here, we'll be recording it in this area. We know it's left atrium. If something starts here, this pair will, the closest to that spot, will be recording it first. That's how we know where it's coming from. In this case, AV nodal reentrant tachycardia, we record the his area and we go back behind it. Usually the distance between the closest is 10 to 20 millimeter. We burn in that area and stop the tachycardia. Again, the most dreaded complication is to damage the AV node and cause pacemaker implantation. That risk, fortunately, with the technology and the knowledge and the practice, is less than 1%. And when we do the ablation, reminder, we do it with the heart beating. And this is the catheters beating with heartbeats. And this is the ablation catheter. When it was here, it was at a beating heart. So you can imagine stability could be an issue. And this is what it looks like on the X-ray. This is RAO, this is LAO, this is the 20-pole catheter of the same patient. This is a catheter going to the right ventricle. This recording right atrium, left atrium, his AV node area, and this is where we burn at a safe distance from his bundle. What does it look like on a 12-lead ECG? Well, again, near QRS, it's fast and regular. It's supraventricular tachycardia. I don't see P wave. It's not sinus, it's not atrial. So you can say, okay, it's junctional tachycardia, just like I said. Yes, it could be junctional tachycardia, but just to let you know, junctional tachycardia, especially the fast one like that, is really uncommon. So think of junctional tachycardia, but think more of AV nodal reentrant tachycardia. And you can see P wave as a little hump here, or the little dip there, like an S wave after the QRS. Why? Because the atria and the ventricles are activated at a very close timing. And it's hard to see the P wave, but it's usually like an S wave or a small R prime. And if you compare the same patient, this is during sinus rhythm. See, the S wave here is very small, no R prime. And this is during tachycardia. You see the retrograde P wave is really prominent S wave, if you will. And if you look at V1, you can see that little dip after the QRS. So this is, whenever you see narrow QRS, regular tachycardia, you don't see a P wave before the QRS, and you see it, or you can imagine it immediately after the QRS. Think AV nodal reentrant tachycardia. Why it matters? We'll talk about that. This is another example, the same patient, narrow QRS tachycardia, about 140, 150 beats a minute. You don't see P wave before, and this is during sinus rhythm. See the P wave during sinus rhythm, no P wave. But you can look at this P wave here after the QRS compared to ST segment during sinus. Without comparison, it's hard to tell, but that shows you when you compare the two, you can really easily see that there was a P wave here that's not there. And that's typical RS, R prime, or pseudo R prime of AV nodal reentrant tachycardia. Well, let's look at the strip here, narrow QRS, regular supraventricular tachycardia. By looking at it, don't feel bad if you can't tell what it is, but you can guess. It could be junctional tachycardia, but more commonly AV nodal reentrant tachycardia. If you give this patient adenosine, like we always do, you tend to stop it all of a sudden and go back to normal rhythm. Why? Because adenosine blocks the AV node, and the AV node is an essential part of that circuit. You stop the circuit, you terminate the tachycardia. If you look at this tachycardia, which is the same rate at 150 beats a minute, and you can't tell what P, what QRS, what STT, you know, you can't be sure. You give adenosine. What happens here? You block the AV node, you strip the QRSs away. Here, you stop the QRSs from appearing because you block the AV node for 4 or 5 seconds, and you see the flutter waves underneath. So taking the QRSs away strips the QRS, ST, and T and gives us a clear view of what the atrium is doing. Why did we stop the flutter? Because the flutter is a re-entry circuit in the atrium, does not need the AV node for the circuit. And you do not stop the circuit, you just simply slow the conduction in the AV node. And once you have this, don't allow that to make you nervous, because the adenosine is very short half-life, but just shows you the diagnostic and therapeutic value of adenosine, which we use a lot. This is to highlight that adenosine in that specific patient went from regular SVT, we don't know what it is, to figuring out it is flutter. And then what happens here? The flutter changed to fibrillation. See those well-formed, identical tooth appearance of those activities going into very fine activity, and that's fibrillation. And that's not uncommon. And you probably see that a lot. You give adenosine, and you go from whatever you are to atrial fibrillation. Why does that happen? Because adenosine affect A1 receptors and cause sinus bradycardia and AV block. That's understandable. But it also activates the outward potassium current and causes shortening of the atrial action potential and refractory period. And that causes atrial fibrillation. Luckily, its half-life is only a few seconds. And if the patient is taking aminophylline, it antagonizes its effect. So you need to give 12, 18, 24 milligram of adenosine. And if the patient is on dipyridamole, you probably need to start with 3 milligram instead of 6 milligram of adenosine, because it blocks its uptake and potentiates its effect. It is safe to use in pregnancy. As we said, the half-life is few seconds. By the time the blood circulates towards the fetus, fetal circulation, basically it's gone. And it has a unique, weird feeling. Every patient who gets it feels it. The many times I use it, I only had one patient who loved its effect, and he asked for more. Did not get it, of course. So this is the adenosine effect showed by intracardiac recording. This actually the patient with SVT, narrow QRS. This is recording the atrial activity from inside, and you can see the atrial activity superimposed on the QRS because they are happening at the same time. You give adenosine, it blocks the AV node, stops the circuit. You end up with a sinus rhythm that does not conduct to the QRS, no conduction. And then what happens here? Fibrillation. You shorten the refractive period and the patient goes into fibrillation. So keep in mind, adenosine blocks the AV node. If it terminates the tachycardia, that circuit is dependent on the AV node. Always exceptions. I just mentioned focal atrial tachycardia at high enough doses of adenosine could be terminated as well, but they will see a P wave before the QRS in case of atrial tachycardia. And also adenosine can cause atrial fibrillation by shortening the atrial action potential or effective refractory period. Now, the last reentrant circuit that caused supraventricular tachycardia we're going to talk about, it's called Wolff-Parkinson-White or orthodromic atrioventricular reciprocating tachycardia. I mentioned earlier that normally the only electrical connection between the atria and the ventricles is the AV node. But you can have abnormal accessory connections. We call them accessory pathways. AV node is a specialized electrical connection that has the properties of ability to slow fast rhythm from going down and allows filling and delay of the conduction of the electrical activity to allow filling of the ventricles. Accessory pathways, they are usually muscle fibers. So they don't understand, they don't care, they don't slow down conduction. Anything that comes their way slips down. Of course, they could be slow or fast conducting, but are usually faster to conduct than the AV node. When you have an extra connection or accessory pathway between the atria and the ventricles, in addition to the normal connection, you are setting the stage. And of course, that extra connection could be anywhere on the right or on the left, with few exceptions in the area of the mitral aortic continuity, because you always have that annuli together with no place for a muscle fiber to come along. So the accessory pathway could be on the right or could be on the left. And it is appropriate for that reentry circuit to go down the AV node, down the bundles, giving us narrow QRS, then up the accessory pathway to activate the atria. And that going down the AV node, down the normal conduction system, up the accessory pathway, down the AV node, up the accessory pathway, gives us narrow QRS tachycardia, and we call that orthodromic tachycardia. When the impulse goes down the accessory pathway, up the AV node, when you go down the accessory pathway, you're traveling down the dirt road. You're not traveling down the highways. And the muscle fibers are not specialized conduction systems, so you're really slow activating the ventricles. And that's why you get a wide QRS tachycardia. And that's what we call antidromic. You go down the accessory pathway, up the AV node, and gives you wide QRS tachycardia. The point I want to highlight, when you have orthodromic atrioventricular reentrant tachycardia, you have to go down the bundles, activate the ventricles before you can get to the atria. So the P wave cannot be inscribed at the same time as the QRS, just like you would see in AV nodal reentrant tachycardia or junctional tachycardia. And it happens at the distance from the QRS, because you go, you finish, then you go up. And that will help us distinguish on the 12-lead ECG, not always, most of the time, or sometimes, between reentrant using the AV node and accessory pathway, or reentrant using the AV node area. This is re-entry using accessory pathway, going up the accessory pathway, down the AV node, or just going up the AV node, down the slow pathway next to the AV node. As we discussed, you have to go down the ventricles first before you can go up to the atria. Here, you don't have to go anywhere. You're just rotating here and go up and down at a close timing. That's why the P wave in AV nodal reentrant tachycardia, either behind the QRS where you don't see it at all, or gives you that inverted P wave like an S wave in the inferior leads. And that's what we just saw as R prime in lead V1. In accessory pathway, the P wave usually happens at a distance from the QRS, because you have to go down the ventricles before you can go up and give the P wave. And you can see the P from the QRS distance versus the P from the QRS here. And usually the P wave is at that distance from the QRS. These are just clues. You can be 100% sure without going intracardiac recording like we do in EP study. But there is a certain joy by looking at all these arrhythmias and feel confident analyzing them and decide which rhythm problem you have. Of course, if you give adenosine in accessory pathway related tachycardia, you go down, give the QRS, that's narrow, down the AV node, up the accessory pathway to give that P wave. You give adenosine, it blocks the AV node and it stops the tachycardia. So the same way, you have regular supraventricular tachycardia with no P wave before the QRS and maybe seeing a P wave after the QRS. Options are mainly AV nodal reentrant or AV reentrant using an accessory pathway. Either way, you give adenosine, it terminates. Clues, that is accessory pathway versus no accessory pathways, is the delta wave. So how do we terminate what we call Wolff-Parkinson-White syndrome? I want to highlight the nomenclature of Wolff-Parkinson-White syndrome. When it was first described, it combined evidence of delta wave or ventricular preexcitation with tachycardia in the same patient. So when we have a delta wave in a patient with tachycardia, we call that Wolff-Parkinson-White syndrome. When we have only delta wave or ventricular preexcitation on 12-lead ECG, but no history of tachycardia, we simply call that ventricular preexcitation. And to stop that circuit, again, ablating the AV node would stop the circuit, but won't be a good option. So we go after that accessory pathway, whether it's on the right side or the left side, and burn it and get rid of it. And if it is on the left side, we tend to go transseptal to get to that side. And this is the X-ray of going across the septum to the left side to ablate that accessory pathway. Clues, if you have your supraventricular tachycardia related to accessory pathway or not, when they are not in tachycardia, you can see a delta wave. A delta wave is part of the ventricles that gets activated by conducting down the accessory pathway. Remember, the accessory pathway does not slow down the conduction. So you do not have that PR segment the AV node nicely gives us to allow adequate time for left ventricle or right ventricle filling. As a result, the atria get activated right away. You get the accessory pathway, you slip right down and start activating the ventricles. So it gives us that delta wave. And this is the part of the ventricles that gets activated through the accessory pathway. And we can all recognize that delta wave happening immediately after the P wave or even within the P wave. And that's why we have a short PR interval as one of the features we look for. This is a representation of sinus node activation down the AV node and the bundles, and you have accessory pathway. The more time you have down the accessory pathway, the more muscle you activate down the accessory pathway, and the bigger the delta wave. And sometimes the whole ventricles are activated down the accessory pathway before it has time to go down the AV node. That's why delta wave sometimes could be very hard to see, and sometimes it's easier to see, and sometimes it's like, what is that? So this is another example how ventricular pre-excitation can masquerade as something else, and we need to be aware of that. And the distinction is not that hard. If you look at this 12-lead ECG, you think this is left bundle branch block, it's wide QRS, it's going down in V1, V2. This is like really typical of left bundle branch block. But if you look at the P wave, and the PR interval is really short and there's no PR segment, so you think, wow, this could be a big delta wave, and this could be pre-excitation. So whenever you see a left bundle branch block, always look at the P wave and the PR segment. And why would an accessory pathway gives us a left bundle branch block appearance? Well, it's simple. In left bundle branch block, what happens? Activity goes down the AV node and goes down the right bundle. Since it cannot go down the left bundle, it activates the right ventricle before the left ventricle. And that activation of the right before the left gives us the left bundle branch appearance. Well, what happens if you have an accessory pathway on the right side? The impulse comes from here, jumps down the accessory pathway, and activate the right ventricle before the left ventricle. Why? Because the AV node is slowing the conduction down, and activation started here first. And that will give us the right ventricle activation before the left ventricle. So left bundle, what looks like left bundle, could be ventricular pre-excitation. Other things you need to be aware of, and this is actually a board question every time I took my cardiology boards. If you look at the 12-lead ECG, you think, well, this is narrow QRS, and we discussed if RS R prime happening, this is not a bundle branch block. As long as it's narrow, it's not a bundle branch block. We look at the P wave, upright in lead 1, upright in lead 2, that's sinus. You may be able to agree with me that there's a small delta wave here, small delta wave here, and the PR segment is not there, and PR interval is very narrow, very short. So this is actually ventricular pre-excitation. If you look here, you see Q wave in lead 2 and AVF, you think this patient has previous MI. In reality, this delta wave is as a result of the accessory pathway activating away from the inferior leads and giving us Q wave. So this patient does not need a heart cath, needs ablation. And the previous example was really good example of inferior. Look at those inferior Q waves. This is all pre-excitation or delta wave. The last part, I think we're doing well on time, is evaluating the AV conduction. The AV node, what gives us the PR segment, and normal PR interval, we said it should be within 1 square. If the PR interval is longer than 1 square, and if every P wave conducts, we call that first degree Howe block. If we have P waves, some conducts and some get blocked, P, PQRS, PQRS, P no QRS, PQRS, PQRS, P no QRS, P no QRS, P no QRS. Whenever we have some P waves that are not conducting, we call that second degree heart block. If the PR segment is prolonging before it blocks, PR, longer, blocks, we call that Mobitz type 1. And when that evolves and progresses to complete heart block, you usually have escape junctional rhythm because the level of the block is usually at the level of the AV node and you have a narrow QRS. So when it develops to complete heart block, you still have some junctional escape that's not very symptomatic. And there is no need for pacing unless Mobitz type 1 is happening in a patient and is causing symptoms with no reversible etiology. When it comes to Mobitz type 2, which is PR segment staying the same before the block, same PR, then blocks, this is Mobitz type 2 by definition. Look here, PR, all the same, then blocks, again the same, and blocks. And you notice that the QRS is wide in both cases. These kind of blocks, or Mobitz type 2 second degree heart block, usually happens on top of existing significant His-Purkinje system disease or bundle branch block. And the level of the block is lower than the AV node. So when this second degree heart block progresses to complete heart block, you will end up with very slow symptomatic rhythm that's escape ventricular, or even worse, no escape. So that's why Mobitz type 2 second degree heart block is an automatic indication for permanent pacing. Mobitz type 1 only when you're symptomatic. The key to distinguish between type 1 and type 2, because you may have sometimes Mobitz type 1, but when you look at the PR segments of the last complexes, they may look the same before they block. Then you say, oh, PR segment is not prolonging. This is Mobitz type 1. Well, that could be tricky because sometimes the increase in PR interval happens at the beginning, and then the latter part of those PR intervals may look the same. So the best way to look at the PR segment to decide if it was prolonging before it blocks is you look at the last one before the blocks and the first one when it starts conducting. Last one before it blocks and the first one before it starts, when it starts conducting. If these intervals the same, you know this interval did not prolong before the block, and that will make it Mobitz type 2. If you look at the first one after the block and compare it to the last one before the blocks, and you can see this shorter than this, even if these two look the same, you know it's type 1 heart block. Mobitz type 1 second degree heart block. One entity I would like to emphasize on is when you have every other beat blocked or every other beat conducts. We look at this, narrow QRS, supraventricular rhythm. Let's look at the sinus or atrial or junctional. We see P wave, it's positive in lead 1, positive in lead 2. That is sinus rhythm. PR interval is normal. But look, P, no QRS, P QRS. This doesn't conduct, this conducts. Doesn't conduct, conducts. This is every other conduction or block. We call it 2-to-1 heart block. We don't call it Mobitz type 2. Because to call it Mobitz type 2 or type 1, you need to have at least 2 consecutive P waves that conduct to allow us to evaluate if the PR is staying the same or prolonging before it blocks. Here, we only have 1 conducted, so you cannot tell. All you say, it's 2-to-1 heart block. Complete heart block is when you have P waves at its own rate and the QRS is at their own rate. You can see the QRS narrow. So we have escape junctional. Remember narrow QRS? It has to be supraventricular. When we have the sinus rhythm happening and escape narrow, it has to be junctional. And the level of the block in this case would be at the AV node. And this is another third degree heart block, narrow QRS, but the P waves and the QRSs are not related and they have their own rate. That's another example of complete heart block. I think that will end the presentation, and hopefully you guys are still there and we still have time for questions. Thank you very much. I can hear you clapping. Thank you very much.